Good evening, everyone, and a very warm welcome to today's session. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my pleasure to welcome you all. This session is part of our ongoing efforts to strengthen awareness and clinical understanding in heart failure management. It is an initiative supported by Heart Failure Association of India with BEAR as educational partner and Voice of Healthcare as the digital partner. Since 2010, European Society of Cardiology has led Heart Failure Awareness Day as one of the most significant global initiatives, bringing attention to the realities of heart failure and acting as a catalyst for change in its treatment paradigm. Building on this momentum, in 2026, the Heart Failure Association of India is taking a step forward to raise awareness around the importance of early recognition of heart failure symptoms, particularly in patients with LVEF greater than or equal to 40%, ensuring timely diagnosis and optimal management. Today's session, titled Beyond Ejection Fraction, is designed to share practical insights on the evolving understanding and newer therapies in heart failure with LVEF more than or equal to 40%. More importantly, this initiative encourages us to move beyond just the numerical interpretation of ejection fraction and instead focus on real world clinical judgment, patient profiling, and multidisciplinary perspective that truly shape contemporary heart failure management. Through this discussion, we aim to bring together expert insights that can help translate evolving science into meaningful improvements in patient care. Thank you once again for joining us this evening. Let's begin the session. It's my privilege to introduce our esteemed chairperson and moderator for today's session. We have with us Dr. Hari Krishnan, Professor of Cardiology at Sree Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, and Editor-in-Chief of Heart Failure Association of India. Welcome to the session, Dr. Hari Krishnan.
Thank you.
Joining us as a distinguished speaker, we have Dr. Abraham Oman, Senior Consultant in Cardiology at Apollo Hospital, Greams Road, Chennai. Welcome to the session, sir.
Thank you.
Dr. Kamal Sharma, Senior Interventional Cardiologist at Sal Hospital, Ahmedabad, co-founder of 𝗙 US and scientific and research-led consultant at Plasma IT, Healthcare IT Vector, Australia. Welcome to the session, Dr. Kamal.
Thank you. Good evening, everyone. Looking forward.
Thank you so much. Dr. Prakash Kumar Hazra, Director and Head of Cardiology at Manipal Hospitals, Kolkata. Welcome to the session, Dr. Prakash. We are truly honored to have such distinguished experts with us today. I now hand over the session to our esteemed moderator, Dr. Hari Krishnan, to lead the discussion forward. Over to you, sir.
Good evening and welcome everyone to this session. As said, heart failure is a major health issue, and the burden is rising as we are already witnessing. The, the important thing is that now we have therapies which can improve the outcome of heart failure. So we have the universal definition of heart failure, classifying heart failure into basically three groups based on ejection fraction. As you all know, less than 40 comes to reduced. Above 40 to 50, it will be mildly reduced. And above 50, it is called preserved ejection fraction. So the management and the effective drugs in these two groups vary. That is what we are going to discuss today. So can you go to the next slide? So today we have a great panel of speakers. Dr. 𝗕𝗲𝗰𝗁, who is the president of the Heart Failure Association of India, and he has implemented many programs to improve the heart failure care, which is our motto. So he will be the first speaker, then followed by Dr. Kamal Sharma. As already said, he is a senior interventional cardiologist at 𝗟𝗏𝗃 Hospital, Ahmedabad, and Dr. P.K. Hasra from the 𝗪𝗲𝗃𝗃 Hospital, Kolkata. So can you have the next slide, please? So the first I will give a small introduction. Following that, a presentation on the fine arts heart failure by Dr. 𝗕𝗲𝗰. Then we have two cases, one by Dr. Kamal and second by Dr. Prakash, and then we have a panel discussion subsequently. And subsequently, I will have some clinical takeaways. Can you go to the next slide? So, what is the current status of heart failure with the preserved and heart failure with the mildly reduced ejection fraction? Go to the next slide, please. Can you go to the next slide? Yeah. So first we will start with some epidemiology. What is the previous slide? Previous slide, please. Yeah. So this is the data from the Trivandrum, the National Heart Failure Registry. Go forward to the next slide. Can you go to the next slide, please? So this is the data from the National Heart Failure Registry, which is published in Nature. So please don't change the slides. Can you go to the next previous slide, please? Okay. So what we did was, in the National Heart Failure Registry, we had around 10,851 patients recruited from 53 hospitals across 21 states and 4 union territories. Next slide, please. It was ICMR funded, and this is the largest heart failure registry in the country with representation across the country. Next slide. The highlights of this registry was our patients was around, average age was around 59, which is the patients are around 10 to 15 years younger compared to the Western patients and even from Chinese patients. And there was a male preponderance in the tune of around 70%. But it is also significantly different from the Western data, where it is almost 50-50 male-female ratio. Whether we are missing the females who is having heart failure, that is one of the points which we can discuss. So this is the heart failure types. The first 4 rows indicates the Indian registries, and the last 2 are the Western registries. You can see that in the first column, you can see that a heart failure with reduced ejection fraction, 2/3 of the patients, around 65 to 68, are reduced ejection fraction. That is the most common form of heart failure in India. Preserved ejection fraction, if you look at the last column, it is around 12 to 16%. That is significantly lower compared to, you can see the lower 2 rows, it is 46, almost 50% of the Western population with heart failure are having preserved ejection fraction. So it's a significant difference where we are missing those cases that we have to discuss. Mildly reduced ejection fraction come to around 22% in the national registry. So above 40%, if you take around 34% of the patients, one third of the patients will be having EF more than 40. Can you have the next slide? Can we have the next slide? So, what is the prognosis of these patients? It's a very important. We all think that heart failure with a reduced ejection fraction had a worse prognosis compared to mildly reduced and preserved ejection fraction, but it's actually not. You can see the middle graph. You can show that The 5-year overall survival with all the three groups based on ejection fraction is the same, 24, 24, 24, like that. Need for hospitalization, 82%, 84%. It is also almost same. So the prognosis of patients who are having more than 40% ejection fraction is the same as that of patients with ejection fraction of less than 40. So that is one of the points which we want to drive. Next slide, please. Next slide, please. So this is the data from the Trivandrum heart failure history, but this shows that the preserved ejection fraction had a lower mortality. There are many reasons for that. We will not discuss that. Slightly different Indian data. But here also you can see that the mildly reduced and the reduced ejection fraction had almost similar mortality. Can you go to the next slide? And readmissions, that is one important. It is Achilles heel of heart failure. 30% of the readmissions occur within the first week after hospital discharge. 60% occur within first week. 30% of them are actually due to heart failure exacerbation itself. And residual congestion, that is very important term. Residual congestion. When they discharge the patients, they are still having congestion. So that is the reason for the readmission in most of the patients. And it is the good thing is that 2/3 of the heart failure readmissions are preventable. That is what we will discuss today. Next slide, please. So again, this is the data from the Trivandrum heart failure. You can see that only a readmission was around 30%. At 5 years, it was around 45%. And at 10 years, we have the 10-year data also, it was nearly around 75 to 80% of the patients had readmissions. Next slide. So you can see that whenever a patient gets admitted, that is an indicator of a worse prognosis. You can see that the first column is single readmission. You can see the second column is second hospitalization, and the last one is last bar is fourth hospitalization. You can see that 2.5% average survival. 4 hospitalizations, you can see that the survival comes down to 6 months. So this is very important. Next slide. So the residual congestion is the reason for many of the patients are having a readmission. So 1 in 5 hospital patients are hospitalized within 30 days of discharge. More than 50% are the risk of being hospitalized within 1 year if the ejection fraction is, even if the ejection fraction is more than 40, and they have poor cardiovascular outcomes. So if we can do something to identify these patients who are having residual congestion and treat them adequately or give some add-on therapies, we can improve their outcomes. So this is the latest guidelines from the ACC and ESC regarding the management of patients with mildly reduced, that is ejection fraction between 40 and 50, and preserved ejection fraction, that is ejection fraction more than 50. So you can take the latest ESC guidelines. Diuretics and SGLT2 inhibitors are class 1 indications for ejection fraction more than 40%. Mildly reduced ACE inhibitor, ARB or ARNI, is a class 2B. 𝗔𝗏𝗏𝗃𝗏 receptor antagonist is class 2B, and beta blocker is class 2B. Preserved ejection fraction, heart failure, ARNI and ARB, and mineralocorticoid receptor antagonists are class 2B in the ACC AHA guidelines. Can you go to the next slide? So the bottom line is that there are a significant number of patients who are, go to the next slide please, who are having residual risk. So that patients we have to identify and do some add-on therapy or some modification of the therapy so that we can prevent the readmissions and improve their outcomes. Can you go to the next slide? So with this introduction, we will go to the next slide, please. So the key messages are basically heart failure with LV ejection fraction more than 40%. Those two groups, mildly reduced and preserved, face a high burden of heart failure, even similar to heart failure with reduced ejection fraction. So that means that the across the EF burden, the prognosis and the outcomes remains the same. And overlapping comorbidities can exacerbate the risk of death, especially when the patients are older. But our patients are 10 to 15 years younger, so the comorbidity part may not play that role. So it is basically the heart failure itself. and there are critical gaps in care persist attributable to the high residual risk that remains in the patients when they are discharged. So that is what you should understand. Okay, next slide, please. So now we'll go to the presentation by Dr. 𝗕𝗲𝗵𝗰𝗁 on the fine arts heart failure, what this means for daily practice. Over to Dr. Umman.
Thank you, Dr. Hari. My topic is fine arts heart failure because, as Dr. Hari said, HFpEF is not a new name. It is named by the charm group just to define something more than 40%, and then it became mildly reduced and more than 50%. Now is preserved ejection fraction. So the major problem for people not looking for HFpEF was that the statement was, oh, there is no treatment for that. And it's a conglomeration of comorbidities. Treat the comorbidities, that is fine. But now we know that it is not so, and we have specific treatments, and like this, we have answers to certain questions, and these answers are brought forth by randomized controlled trials. And this is fine arts, one of the pivotal randomized controlled trial in HFpEF, because till the 𝗪𝗛𝗄 and delivered with SGLT2 inhibitors, we had a series of what I would call as tragedies where narrowly missing superiority, sometimes regional differences, etc., etc. So after deliver and 𝗪𝗛𝗄, this was a blockbuster trial, which gave us clarity in approaching heart failure with preserved ejection fraction. Next slide, please. So, next slide, please. So, FINEARTS before that, okay. So before fine arts, there were Fidelio, Figaro, Fidelity. They were essentially diabetic kidney disease trials. But with that, they looked at cardiovascular events also. And then they found that, okay, diabetic kidney disease patients, FINEARTS is very good in preventing cardiovascular outcomes as well as renal outcomes. So that, but essentially they were DKD trials. That is why with that, ESC gave a class 1 indication for FINEARTS in patients with diabetic kidney disease in preventing heart failure. And that was where we stood. Then came fine arts. Fine arts is interesting because the fundamental tenets of Figaro and Fidelio is not mandatory here. What are the fundamental tenets? One is diabetes. It's not mandatory. And we know that in fine arts, it even prevented the development of diabetes. And kidney disease, it's there fine. Essentially, it was a pure HFpEF trial. That is very important because there can be questions whether it was diluted by other things. So then the cutoff of GFR was 25 and the potassium was 5. Next slide, please. So this, next slide, please. Right, so moving slowly. So we can see the patient characteristic. They were similar to the contemporary heart failure trials. And so that can be comparable to pivotal, deliver, or 𝗪𝗛𝗄. And again, look at the age there. This is an elderly group. But Indian group, like Dr. Hari Krishnan said, it's a much younger patients. But are they very different? When we looked at our heart failure clinics data of HFpEF, some interesting things we could find was the central obesity, waist height ratio was more than 0.5 in more than 90% of the patients. So visceral obesity was ubiquitous. And another interesting thing what we found was that we looked at the frailty, like there are many ways of checking frailty. And one is hand dynamometer. We found that even comparatively younger people are frail in the sense the grip strength is less than 25 or even lower. So maybe they are chronologically younger but biologically older. We do not know. But fine arts was similar to the contemporary trials. Next slide. So fine, and you can see patient had prior heart failure. Look at the number of diabetes, about 40%, and so and it's a broad range that is important. And the cutoff of ejection fraction was 40%. It is not 50%. So it included mildly reduced or erstwhile mid-range and pure HFpEF. And more patient had acute heart failure, recent hospitalization, and recent discharges, etc. Next slide. So this is a comparatively broad canvas, and this brings us to the question or discussion point. And I think this question, partly my part, I answered. What I see is that when we looked at like our own heart failure clinic, August 15, 2025 to January 1, 2026, we looked at all patients with risk factors, with any echo changes, we did the NT-proBNP. And interestingly, what we found was that HFpEF was more than HFrEF. And females were quite, numbers were almost equal, frailty was more, central obesity were more. And these were the demographics we saw. They were much younger, 10 to 15 years younger. And again, CKD we found about 24%. So these were the demographic profiles which we saw. And another important, we were doing the mainly two biomarkers at least, that is NT-proBNP and urine albumin creatinine ratio. And urine albumin creatinine ratio is mandated every year for every diabetic in all the diabetic guidelines. But whether we are doing it or not is a different issue. We have to do. It's not a very expensive thing. And it's not costly also. And it is a marker for heart failure. It's a marker for cardiovascular mortality. So again, I think we can get the opinion of all the three, whether it can be considered as a cardiovascular mortality biomarker, something akin to ST2. So our patients are a little different, but not different. So that is the demographic profile we saw in the heart failure clinics. And over to Dr. Hari, Dr. Kamal, and Dr. Hasra for their opinion.
Dr. Kamal, do you want to discuss something now, or you want to go to your presentation and then come back?
Yeah, I think we can take it together if that's fine with you.
Yeah,
whatever you suggest.
Please go ahead. Yeah, Dr. Kamal, what is your comment on this? So from whatever data which we have seen, the patients are significantly younger, around 10 to 15 years. That is what most of the registers have shown.
I completely agree on that. It's I think the real world setting. I think Indians do it a decade early. We do it for everything early. Actually, we have CAD early, we have RHD early, we even have heart failure early, and I think it's congruent with that. We are genetically predisposed in a vulnerable environment, in a vulnerable genetics, in a vulnerable high incidence of comorbidities and risk factors, which actually contribute to it. Is my screen visible?
Yes.
Okay. Shall I proceed? Show the key?
Yeah, I think they will show the
If it's okay, I can move my slide.
Can you move to Dr. Kamal's presentation?
I think, is my slide and screen visible if they allow me? Is it visible? Is my screen visible?
Yeah.
Yes.
Yeah. Okay. So I'm going to discuss a vulnerable post-discharge patient. And as was being discussed by Dr. Abraham and Dr. Harikrishnan, first hospitalization, risk profile in current therapy, and this risk stays, it doesn't go away. So your patient here, assuming that it's a 73-year-old woman, heart failure with preserved ejection fraction, who's got hospitalized for heart failure 5 years ago, and now it presents with fatigue during activities. In 1 year, the patient had complaints of edema both legs, and now the patient has been put on SGLT2 with an EF of 62 and hypertension at the first 5 years back presentation. Uh, just one day ago, patient of hospitalization gets to the congestion and up-titrated diuretic and slightly stabilized. Patient is prescribed diuretics ACE and beta blocker. Now it will be interesting as what could have been done differently, but 5 years ago we did not have any evidence to choose anything differently. And of course, this is a fictitious case. She is a 73-year-old hospitalized with acute decompensation, A1C of 5.9, pressure 131/85, EGFR 65, USCR of 50. Now this is a different subgroup. Unless Fidelity and Figaro we look at, where the definitions were done by USCR and DKD, which was defined with a different subgroup of USCR cutoffs, EF of 62 class 3, and SGLT2 diuretic ACE and beta blocker. So the primary concerns in this case is what we actually are looking at. So this patient scenario, who's at high risk, early and recurrent rehospitalization after the first event, and is there a need for early clinical benefit following treatment initiation with Finrenone? Would this patient subset benefit from the same? From that perspective, Dr. Harikrishnan, Dr. Abraham, and Dr. Hajra, I think we can first take the viewpoints, and then maybe I can proceed with the other slides.
Okay. So this patient now, any patient who is discharged with heart failure, so you have to be very, very closely follow up that patient. That is the first point. The first
Correct.
review is supposed to be the best when you are reviewing here in the 7 to 10 days. But most of the time it may not be possible in an Indian setting where the clinics are busy. So you can see at least the first 2 weeks, you should review the patient and see the hemodynamic status. So that has shown to improve the outcomes. And when the patient is discharged, also going to be discharged, you should look at residual congestion, like whether it's a residual JVP is still elevated, is there any residual crepitations, and the patient is off diuretics off IV diuretics for the previous 24 hours. They are on stable dose of diuretics. These should, if you make sure that you can reduce the chance of a readmission. So that is very, very important. And first week review definitely helps in mild adjustments of the therapy, and that can reduce the readmission, which is the most important issue. And Abraham, is there a need for a clinical benefit following treatment initiated with Finrenone? What is your opinion on that?
Yeah, because these are high-risk patients, and we are seen from fine arts, because this particular patient is like a fine arts patient with the USCR of 15. That's what I could see. So it may look innocuous. Okay, if the cutoff is more than 30 and 30 to 300, more than 300, etc., etc. But the important thing is the risk starts rising even at a USCR of 15. So this patient has got, to me, multiple high-risk factors. The first factor is that patient had an hospitalization. Having a hospitalization is a high-risk situation. He is in the vulnerable phase. He can get readmitted, and he is a high-risk patient. So this is a high-risk patient. So we need this particular patient requires aggressive therapy, proven therapies. I would start him on Finrenone in the first visit, or even at discharge itself. Why I do at discharge is that maybe like I can check the potassium. Potassium is supposed to be checked within 2 weeks, then maybe once in a month or so. So like I would be, if the patient is stable, I would start, because it's not very high potency and patient is hemodynamically stable, I would even start at discharge so that we'll get the early benefits.
Okay.
Yeah, right. I think sometimes I play around with the choice of diuretics, because in half FPEF, we know that diuretics and SGLT2 are currently class 1. Diuretics, as this case also showed some edema. I think what I usually do is that I still continue to rely more on the good old furosemide than torsemide, because we know that between the two there is no difference in event outcomes. However, the potassium levels in toric study showed that potassium level is higher by zero point 0.7 in torsemide arm compared to furosemide. So when I have to choose an MRA, even be that Finrenone, I think I would stick probably to the good old furosemide unless I don't need a high potency diuretic. That's where sometimes I actually play around with, and probably that's why, at least I feel that the risk of hyperkalemia can to some extent be blunted by changing between them. Also, I think I would like to bring in your comments on RP versus ACE, because as Dr. Abraham was mentioning, this fundamental principle of 0.6 p equal to 0.06 has been there for Paragon, has been there for other trials of late like Victor, or for that matter, trials with surmount CVOT, etc. But I think we learned about it from Paragon, and in patients with a preserved ejection fraction had a trend towards benefit, though not reaching statistical significance with RP. So, comments on that, any of one of you, Dr. Hari Krishnan or Dr. Asra or Dr.
Okay. Okay, can we go to the? Can you continue with your presentation, Dr. Kamal?
Okay, I'll do that. So the whole idea, the question that we raised, effects of Finrenone on readmission when you look from the fine arts. The readmission is something which is actually very significantly reduced. 30-day readmission has been brought down almost to half, 1.8 versus 3.6 in the placebo arm. And there's 17% of patients who were randomized during or shortly after hospitalization. This was even more robust. And this happens within 1 month, and it continues to get benefit at 2 months and 3 months. Also, if you look as to what type of outcome we are looking at, whether it's CV readmission or all-cause readmission, the all-cause readmissions don't change, but heart failure hospitalizations do. So in patients who were randomized in fine arts, after expressing an adverse event or serious adverse events, they were similar between Finrenone and placebo, which means that treatment with Finrenone during or shortly after heart failure hospitalization is not only well tolerated, but it reduces early hospitalization in mid-range versus HFpEF subgroup. So EF more than 40%, if you add a previously hospitalized patient, probably we are going to get benefit out of it in terms of preventing a readmission rate in the fine arts subgroup. So again, what are the concerns for this patient who are combining Finrenone after when administered with SGLT2? When you look, I think the benefits would actually be independent of the two. So when you look at the relative treatment benefit in terms of the reduction in the relative risk reduction of CV death or first worsening compared to the standard there with the non-steroidal MRA versus SGLT2, both of them, they do reduce. Net number to treat for them is 32 and 31 respectively, which goes on to mean that probably both of them have nearly a similar efficacy in terms of reducing event rate by 18 and 16% respectively. And then you combine the two, actually, it goes down even further by 31%. And there the odds ratio actually is more in favor of the combination therapy. So Finrenone reduced the risk of CV death and total heart failure hospitalization, regardless of concomitant use, whether it was there on background or not. 13.6% of fine heart patients were treated at baseline, and hence the safety not only suggests it's well tolerated when used in combination, but serious adverse events were reported only in 38.3% with Finrenone versus 41% with Finrenone versus SGLT2, which means that it doesn't get actually further worsened. It actually continues to be on the lower side. So key take homes are that Finrenone demonstrated a 16% risk reduction in CV death and heart failure hospitalization versus placebo, with benefits seen at 28 days. And these remain consistent regardless of how recent the heart failure event was. And the benefits were regardless whether the patient were put on SGLT2 or not, with a strong background therapy in fine arts. So thank you very much. Over to you, Dr. Hari Krishnan, for discussion and presentation.
Okay, so Dr. Abraham, what is your
Again, your voice is kind of cracking. So,
Yeah,
can you hear
Hasra,
me?
you can, yeah, Dr. Hasra, you can mute.
So, essentially, we skip one part, that is the fine arts results. So, what is the fine arts results? Is that it
Dr.
had a
Hasra, can you
clinically
mute?
it had a clinically meaningful 16% relative risk reduction in the composite of cardiovascular deaths and total heart failure events with a number needed to treat of 31. So that is important because the absolute risk reduction is about
Dr. Hasra, can you
2.8.
please?
So the number needed to treat of 31 and absolute risk reduction of 2.8 per 100 patient years is very good. There was significant improvement in the KCCQ or the quality of life, NYHA class, and of course there was improvement in the kidney outcomes. All-cause mortality was reduced 7%, but that is something which we can discuss. And it is a safe drug. That is something which we have to remember, because critical more than 6 hyperkalemia was also much less. So, in short, Finerenone is a fine art showed that Finerenone in HFpEF in a broad range is a safe drug, effective drug, reduce cardiovascular mortality, all-cause mortality numerically reduced, and heart failure hospitalization reduced, with the price to pay of severe hyperkalemia very less. So benefits more, risk less. So that is essentially fine arts. And then subsequently the further detail, recent admissions, recent hospitalizations were discussed. Over to you, Dr. Hari.
Is there any difference in the outcome of patients between mildly reduced and preserved, like 40 to 50 versus more than 50? Was there any subgroup analysis done on that?
Oh yes, it was published, and irrespective of the ejection fraction, fine arts was superior, the Finerenone was superior to the placebo, and line was flat. So now we know that all across the EF spectrum in HFpEF, Finerenone is superior. And another thing was, many trials had not included patients with improved EF. So improved EF was again a no man's land, because the original heart failure trials or HFpEF trials included, because any time EF was less than 40, it was excluded. But if my memory serves right, Deliver and Fine Arts allowed them, so that's another category which could be which found to be useful. And across the EF spectrum, Finerenone was useful.
Yeah, improved ejection fraction is a totally different thing, and I think we should continue the GDMT which we were using in HFrEF in those patients. Finerenone probably can be there, but I think we should continue the 4-drug GDMT in patients with heart failure with improved ejection fraction. That is another thing we should remember. Okay, so Dr. PK Hasra's voice has a problem. So, Dr. Hasra, can you try presenting it from the mobile if possible? Or you can be through the mobile. Dr. Hasra, can you hear us?
Yeah, I can hear you.
Can you start?
Yeah, so can you move the slides?
Can you move the slide, please?
So, newly diagnosed outpatient, that means there are some people who will be living with heart failure, but when they are really very, very symptomatic, they come to the doctor, physicians, and here is a man, 62 years, not too elderly, not too young, history of dyslipidemia, hypertension, and type 2 diabetes mellitus in the heart failure clinic. That means the clinic is well equipped to treat, to prognosticate, to give future directions of a newer drug, which is Fineron for the time being in our discussions. And the diagnosis of HFpEF, that means we had many drugs in the past which has failed, but will be pushing or adopting this drug in heart failure with preserved ejection fractions. Definitely in a man who is hypervolemic by the presence of leg edema, dyspnea, you have to classify which class 2 or class 3. Ideally, these patients can present with class 2 to class 3. They are usually not in class 4, and fatigue is one of the symptoms of heart failure. So he's having classical heart failure. And since we have put a diagnosis of HFpEF, ejection fraction has to be more than 40%. In some trial, it is 45%, especially in the diabetic heart failure trial like Summit trial. But all the heart failure, they have taken 40%. So current treatment is ARBs. Maybe some objections in the ARBs because we have ARNI in the pipeline or in the guideline. Loop diuretics for 1 month. That means he is on some form of drug. In spite of that, he has developed the fluid overload. So loop diuretics has to be adjusted. And metformin and SGLT2. Key lab findings: GFR, good GFR. And as we go down with the GFR up to 25 ml, there is a concern that the potassium will go up. But the lower the GFR, the greater the benefit on the kidney outcome. So 10 years diabetes means he has already some form of diabetic kidney disease. Now we know that all diabetics do not behave equally. Some diabetics, they escape kidney disease. Some diabetics, they do develop kidney disease at very early age. All depends on genetics. And the type 2 diabetes doesn't mean they have all insulin risks. There are different forms of type 2 diabetes. Now there are 5 clusters. So BMI is 29, that means overweight. And this overweight could be due to the dry body weight or wet body weight. That means once he is diuretic properly with a lot of loop diuretics, his BMI should be remeasured. But he is 62 male. That means he is forming a group of people by WHO or any obesity definitions. The BMI fits into obesity. During a follow-up visit, he remains symptomatic. That means his GDMT may not be adequate. In spite of having ejection fractions, a good ejection fraction, if he's not getting any symptoms, you have to introduce new drug which can take care of the kidneys, diabetes, and new onset of atrial fibrillations, heart failure hospitalizations. At the end of the day, the cardiovascular death. He was advised to do echo and NT-proBNP levels. That is not mandatory, but we do measure NT-proBNP just because there are sometimes the dyspnea could be due to COPD, so that will differentiate between heart failure and COPD. And we can re-estimate this proBNP on serially so that whether the patient is more diuretic, less diuretics, or no diuretics, whether the drugs are doing well. All these informations will be available on NT-proBNP level. So heart failure with preserved diagnosis, preserved ejection fraction diagnosis is confirmed based on ejection fraction 55%, and they should have some kind of strain imaging also, LA volumes, structural information should be there, and you know nowadays we know that structural heart information is very important to introduce this new class of drugs. And as we go down with the this pooled analysis, FINEARTS-HF, Fidelio and Figaro DKD, as we have failed to reduce the cardiovascular death as a separate outcome on hierarchical basis in FINEARTS trial, we could achieve the same cardiovascular deaths if you pull all the data, and that is basically Fidelio DKD, Figaro DKD, and FINEARTS-HF trial. So what you have seen in this cumulative figure that the CV benefits and kidney outcomes is definitely with the Fineron cardiovascular death, excluding unknown deaths. So if you exclude unknown deaths, 11% reductions and p-value is 1.01. Once you include the unknown deaths, like this 𝗪𝗪𝗃𝗵𝗺 trial, initially known deaths and unknown deaths, and unknown deaths in the bastion of heart failure, we always take it as cardiovascular death, cardiac death, until proved otherwise. And if you include those numbers, it is significant. Kidney composite endpoint, heart failure hospitalizations, CV death, or heart failure hospitalizations, all are significant with a significant p-value. All cause death, all cause hospitalizations, all are in favor of heart failure. This trial, and I think we will go to the disappeared. I think. Yes.
Dr. Hasra, we can't hear you.
Yeah, it can hear me. Yeah. So can I go to the? I think I lost somewhere. Sorry, just give me a minute. I think I lost the screen. I don't know why. It's very
No, we are
complicated system.
able to see the screen. You can see the screen.
Oh, okay, see the screen now. Sorry. Give me a minute. Just a minute. I'm not able to see the screen.
It's a case 2 showing that the patient mostly resembles FINEARTS study population.
Yeah. No, I'm not able to see the screen. Suddenly disappeared. Anyway,
So we can see the screen. You are not able to see. Okay. Anyway, this patient closely resembles a FINEARTS study population because age was more than 40, to class 2 to 4,
this case, the
age
age is
more than 40.
years. Heart failure diagnosis, class 2 to 3, ejection fraction. All these are fitting into the main inclusion criteria of FINEARTS heart failure study, and EGFR less than 25 is been excluded. So there is a concern of continuing this FINEARTS if the GFR falls below 30, and then perhaps you have to be very careful about the potassium if you are really continuing this FINEARTS on a tender zone of 25 to 30. And perhaps you have to bring other drugs like Localma and potassium binding agents. So ProBNP, here you should have this ProBNP, 2-proBNP if somebody is in sinus rhythm and somebody is in atrial fibrillations. So this patient fits very well into the trial criteria of inclusions and trial criteria of exclusions. So he's the right candidate for FINEARTS. Next. Can I move to the next?
Can you show the next slide, please?
Next slide, please. Next slide, please. Yeah. So, FINEARTS is now approved for use in adult patients with left ventricular ejection fraction more than 40% to reduce the risk of cardiovascular death, heart failure hospitalizations, that means number of events are reduced, urgent heart failure visits in the emergency clinic or the physician's chamber. So to summarize this case, 62 years man with ejection fraction of 55%, long duration of diabetes, stage 2 secondary hypertension and overweight patients. They should be managed, this type of patients should be managed with the furosemide-like medicine, empagliflozin, FINEARTS, along with lifestyle modifications. Next. So FINEARTS can be increased from 10 to 20, and if you are really going into pure heart failure, if rejection fraction falls further, perhaps you have to increase the dose from 10 to 20, 20 to 40. But if the ejection fraction and the creatinine level is going in different directions, for example, if the creatinine is falling down, creatine going up and the GFR is falling down from 20 to you have to come down to 10 milligrams. So those kind of permutation and combination can be done depending on your potassium and the GFR level. Next. So in this slide, it has been shown here that at day 28, the first statistical significance comes if you are using Finerenone. So it's symptomatic heart failure. Your Finerenone therapy should be started very early, and that should be combined with other guideline-directed medical therapy. On follow-up, there is a persistence of the benefit of Finerenone. So early use and sustained clinical benefits tells us that if you really want to reduce cardiovascular death and total heart failure events, you should include Finerenone in the prescription of heart failure with preserved ejection fractions. Next.
Next slide, please.
This we have actually already discussed. Next. So the parent question: who is the right patient? Is initiating Finerenone in an outpatient setting appropriate? What challenges exist in choosing Finerenone to outpatient department? What follow-up protocol should be implemented for monitoring serum potassium and eGFR? Over to you, sir.
Thank you, Doctor. So this patient which we were discussing, can you mute? Yeah. This patient we were discussing, the ejection fraction was 55%. So I think patient is on ARB. I think there is a role for changing from ARB to ARNI in such patients, because the less than 55 EF there is some benefit with ARNI also. Then control of diabetes would have been better. These are the things which have been the points which I can add in addition. Dr. Abraham, can you answer those questions? Finerenone, are you comfortable in initiating in the outpatient settings? You are muted, Abraham.
Sorry about that. Okay, I believe that it's appropriate because we have very few positive randomized controlled trials in HFpEF, especially when you go to the higher levels of ejection fraction. And Finerenone and SGLT2 inhibitors are the two things which works across the spectrum of ejection fraction, and reduced events and improved quality of life and reduced BNP, NT-proBNP. So it should be appropriate, because if you do not do so, then the quality and quantity of life of patients would be affected. So that would be my take on that particular question.
Dr. Kamal, what challenges you expect when you start Finerenone in a patient, when you start in the OPD? So,
yeah, usually it's the potassium and the eGFR, but we must understand that the other MRAs, firstly, don't have evidence in this subgroup of patients so strong. We know 𝗕𝗁𝗃 failed. We also know that in EF more than 40%, most of the data sets are negative. Plus the cutoff for eGFR there is 45. Here for Finerenone is 30. So I think I don't see much of the challenge except potassium. And again, in the trials that have looked into potassium levels, most of the times, whether it's B with ARNI or ASA or ARB, the potassium levels tend to go up, but most of them are not life-threatening. They are in the range of 5.5 to 6, rather than more than 6.5 or 7.
Okay, Dr. Abraham, what will be your...
So my starting is, of course, anything which is below 5, but then the trial inclusion was up to 5.2. But I think one should be cautious. And as I mentioned, most of the times what I do is choose furosemide rather than torsemide. And most of the times it's pretty fine to get along with. Of course, as Dr. Hazra was mentioning, choosing sodium zirconium picosulfate, that's Lokelma, is one of the choice you can add up to if the indication is so strong to actually choose the one.
Dr. Abraham, when will you consider doing a serum potassium assessment when you are starting this patient on OPD basis serum potassium?
At 1 week, at 1 week, I would ask them to do the potassium, and then after 1 month, then if the potassium is stable, then I would do it only once in 3 months. Again, the problem is the hyperkalemia is the old 𝗪𝗏𝗃𝗃 data, which holds very much true, is that if the GFR is more than 45, chance of hyperkalemia is extremely low. But if the GFR is less than 45, then I would be careful, and especially if it's nearing 30-ish or so, I would check it every month, because hyperkalemia, it is rare, but we have seen cases where potassium has gone up to 6.5. I never had a patient more than 7, but like very, very few, and they had other reasons for it also. And again, like if they are ARBs, should be titrated, and so that would be my approach for potassium.
So will you consider changing to ARNI in this patient, or you will continue with the ARB?
$1,000,000 question. I was part of Paragon, so I got a soft corner for ARNI. Cost is a factor, but females and the EF is less than 57. That is 2 subcategories, but that female thing was not replicated, but still, like females and EF less than 57. And I got another criteria of mine is I look at GLS, and the GLS is on the lower side. I would go towards ARNI. Another thing is that the finerenone reduces new onset atrial fibrillation, which is very common and very important in FF. It reduces the chance of getting diabetes too. So, and we have to understand that spironolactone increases hyperglycemia, increases HbA1c. So, and inflammation is less. Inflammatory markers are less with finerenone compared to eplerenone and spironolactone. So it goes over in multiple ways. So that would be my go-to drug in heart failure with preserved ejection fraction after SGLT2 inhibitor.
Okay, so at what level will you withdraw the drug when you see regarding the potassium level?
Like I am very comfortable till 5.5, more than 5.5. So if it crosses 5.2 or 5.5, I will reduce the dose. I've gone up to 40 because in FINEARTS, the dose, the up to 40 was permitted. Fidelio-Figaro, it was 20. And I would reduce the dose. I may give a drug holiday, but I would look for other causes. Many times there are other causes, and many times, so I would look at the other cause of hyperkalemia, high potassium diet, and 5.5 is my magic number. For nephrologists, it's 6, but anything up to 5.5, I'm comfortable with. So that is my magic number.
Dr. Kamal, do you have any thoughts on this regarding potassium? Do you give potassium binders if it is probably 5.6 or 5.7? Will you consider potassium binders?
Yeah. I think anything above 5.51 needs to be very cautious. The bigger worry when the potassium starts rising is that you are actually looking at probably an acute decompensation of renal function as well, because I think it's probably a harbinger. It's a sign that kidney is not able to handle the potassium adequately. You may soon have the eGFR dipping in. So I think it's not just the potassium, but also the eGFR, which you need to be looking at. And either of the two would be a worrisome sign, and you probably need to have a relook, temporary cessation apart, change in the medication, hydration, etc. is something that we need to figure out as to how to go about it.
Regarding the point Dr. Abraham said regarding the prevention of new onset atrial fibrillation, I think SGLT2 inhibitors also have an effect on preventing the new onset atrial fibrillation.
Yes,
Both these agents will have a synergistic effect in reducing the new onset atrial fibrillation. In that way,
Right.
it is good in patients with HFpEF because they are having a atrial fibrillation as one of the common accompaniments during their course of the illness. So can we move to the next slide? Okay, this is the third case or the same patient?
Same
I
patient
think it's the
summary.
summary of the last case, actually.
Oh, okay,
This is
okay.
not third case. Yeah. I think Dr. Hajra didn't present this, but I think it was same. I think we have discussed all this. We can have the
Okay,
next slide, and so I think this is the one. I think Dr. Harikrishna, you need to do the takeaways.
okay. Okay, any other points to discuss, Dr. Abraham and Dr. Kamal?
No, I think it's important that this therapy is already class 2A. I think we are inching towards one more trial, and then you probably will have a outcome across the spectrum as to move this therapy to class 1. And non-steroidal MRAs are the way forward. The outcomes which have been now moving from class 2 molecules, I think it's matter of time that this therapy would be able to show it in the reduced ejection fraction as well, where then it can cater to the whole spectrum of heart failure rather than being EF centric, which is right now the case as far as heart failure is concerned. That's my take.
Abraham, any comments?
Yeah, my comments are HFpEF is common, HFpEF is dangerous, and SGLT2 inhibitors and finerenone are synergistic. They reduce new onset diabetes, reduce HbA1c, reduce atrial fibrillation, works across the spectrum, reduce heart failure hospitalization, has got a similar trend and reduces USCR together tremendously, which I think is a death marker like ST2, at least cardiovascular death and in diabetics. So all those things it has to, but only thing is utilization is less unless we give the medications, patient won't benefit. And my cutoff blood pressure is 90 when the study was 90, and it does not reduce the blood pressure very dramatically, but I'll be very comfortable above 100, 90 to 100. I'll be a little careful, ask them to check the blood pressure very often.
Thank you, Abraham and Dr. Kamal. I think we had a very good cases and we had a very good discussion. So the clinical takeaways, as they have put it, I think heart failure with the preserved ejection fraction is common actually than what we think. We may be missing many cases. And the one point to highlight is that they have almost the same prognosis as heart failure with reduced ejection fraction regarding the mortality or regarding the quality of life. Coming to Indian patients, probably we are having a younger group of patients, and now we have a recent array of therapy which is found to be beneficial, like the SGLT2 inhibitors came first, and now we have finerenone which is found to be useful in patients with more EF more than 40%. It is a relatively safe drug. We have to initiate in the correct patient, and we have to follow the patient mostly by seeing the potassium levels and also the eGFR levels. So it will improve the outcomes, and as both the panelists have put, it's other effects also, like reducing the arrhythmias like atrial fibrillation. So I think it is a very useful drug, and as Dr. Kamal has put it, there are more trials coming up, and in the coming months and years, we will have, probably this will move from class 2 to class 1 at some point in time. With this remarks, I will close the session. Thank you everyone for joining from different parts of the country, and good night.
Thank you. Good night.
Thank you.